It's a couple minutes after noon, so let's go ahead and get started. My name is Ron Washburn. I'm a full-time VA infectious disease doctor with a cross appointment at LSU. And I've chosen to talk about antimicrobial stewardship this morning, which may not be one of the most interesting topics in the world, but if you're a kind of person who likes to conserve resources and save money and things like that, it's somewhat attractive. That's one thing I'd like to say. Another is that it's important to talk about it in the sense that increasingly antimicrobial stewardship programs are mandated in healthcare facilities across the United States, including now throughout the VA healthcare system. So a high percentage of all VA facilities nationally have some type of antimicrobial stewardship program in place and operational. Another point is the Joint Commission definitely examines antimicrobial stewardship issues when they come around to inspect hospitals, so we have to pay attention to it. Having said those things, stewardship programs can also do some good things for patients. So some of the major goals are to decrease unnecessary antibiotic usage, which can also lead to decreased resistance among bacteria and other pathogens, and has also been demonstrated to decrease rates of Clostridium difficile infection in hospitals. So good things come from well-managed stewardship programs. Also, because I didn't make a separate slide about it, I should give you a disclosure, which is that I am a shareholder of several pharmaceutical stocks, something that I highly recommend to ID doctors who don't get rich by earning salary. So investments are very attractive. And finally, I want to point out that I left copies of the LSU and VA antibiograms from the microbiology lab up on the front table, if anybody would like to pick up hard copies. So having said all that, of course, feel free to jump in and ask questions, especially if anything isn't clear or requires clarification, and let's get started. So we have a stewardship program at the VA, and at the end I'm going to focus on that and what our numbers have been, and that may be of some interest. But first, let's give a case presentation that kind of makes the point why it's so important to be focused and meticulous when making decisions about who to start on antibiotics and what antibiotics to start. So here's a case from the VA a couple of years ago. A 68-year-old man with insulin-dependent diabetes mellitus and coronary artery disease was admitted to the hospital with 4 months of weight loss, followed by dyspnea, fatigue, malaise, nausea, vomiting, and right upper quadrant pain. On the day of admission, he also noted a subjective fever, and in fact, his physical exam did show a temp of 102, tachycardia, and increased respiratory rate, and epigastric tenderness. Lab abnormalities included an elevated white blood cell count with a left shift, a microcytic anemia. Portable chest x-ray was normal. Blood cultures were drawn, and the patient was started on IV vancomycin and Zosyn, which is probably our favorite cocktail at the VA for sick-looking patients with fevers. Then on hospital day number 4, the updated blood culture reports identified group D strep, not Enterococcus, susceptible to vancomycin, clindamycin, and erythromycin. By that time, after those 4 days of vanc and Zosyn, the patient was afebrile and the follow-up blood cultures were sterile. The home team switched the patient to oral erythromycin. On hospital day 6, 2 different ID attendings at the VA received calls from one of the patient's team members asking for generic guidance for appropriate duration and route of antibiotics for treatment of bacteremia without mentioning the patient's name or the specifics of the case. But questions led to some answers. And the response from both ID attendings was, it depends. And although those 2 particular ID attendings don't agree on very much, they both agreed on the issue of being curbsided about a potentially fatal bacteremia. In fact, one of those attendings said, I think that could turn out to be strep bovis, and that's a common cause of endocarditis. Maybe you should do an echocardiogram. So that was done later the same day. Excuse me, okay. And it showed a vegetation on the aortic valve and severe aortic insufficiency. Also, colonoscopy revealed a large sigmoid mass. And yes, as a matter of fact, the updated speciation of that strep species was Streptococcus galolyticus, which is in a constellation of bugs, which is really what the older clinicians in the room know as strep bovis, which is strongly associated with primary GI pathology like colon cancer. Kirby-Bauer testing of the organism showed that it was susceptible to penicillin, ampicillin, and vancomycin. Then ID was consulted and recommended switching to a more potent regimen than oral erythromycin, which was IV amp and gent. So I think this case helps to make the stewardship points. Why is antimicrobial stewardship important? It's all about the patient, isn't it? It's about treating with the right drug at the right time for the right reason, in the right amount, in the right form, for the right length of time, with the right follow-up and care, and with an effort to minimize adverse consequences. Those are hard things to do. The VA has gotten very serious about this proposition and has a strong national leadership team that's really based kind of all around the country. The national chief of ID is Gary Roselle, who works at the University of Cincinnati and the Cincinnati VA Medical Center. Matt Getz is a senior physician at the Greater Los Angeles healthcare system. There are a couple of pharmacists involved, one in the South Texas Veterans Healthcare System and another in Oklahoma City. These folks run conference calls and slide presentations online for us monthly, open to all ID clinicians. So the concept there is that stewardship has to be a team effort. The stewardship team is comprised of several elements. And they can't accomplish anything in a vacuum. And by that I mean that in order for them to be effective, they have to have buy-in from many sectors of the facilities they work in. They have to have buy-in from leadership. Hospital leadership has to give them the authority to review charts unsolicited and make unsolicited recommendations to clinicians. The chief of staff sorts, the chiefs on the clinical side have to buy in. The providers themselves eventually will buy in if they see that the suggestions make sense and that education is offered as a component of the suggestion, so that it's not just, you know, you're doing something wrong. It's that maybe this could be done a little bit better and here's the evidence base for it. So locally, we do have that interactive team put together of a lot of different individuals. So the team itself includes pharmacy, pathology and laboratory medicine, infection prevention and control, and ID physicians, including attendings and fellows. And then, as I mentioned, the support or the buy-in also comes from all different levels of the hospital. I'm going to be saying a lot of different things through the talk, and sometimes you're going to be wondering what the evidence base is or where I get it from, and pretty much it's all in the IDSA guideline about antimicrobial stewardship programs, so I've listed that here. So one of the major goals of stewardship, of course, is to reduce unintended consequences of antimicrobial therapy. Like what? Adverse reactions. You might be surprised how frequently when we're doing our twice weekly audits of ICU charts that we may find that patients are actually receiving antibiotics that they're said to be allergic to, and then we focus on that and try and figure out whether they're really allergic to them or not, and then work around those issues. Another unintended consequence, which is a very big one in the 21st century, is this news that just won't go away. We're almost getting numb now to the news of the increasing array of organisms with bigger and better resistance mechanisms, both in the gram-positive world and in the gram-negative world. And those bugs are important because they're actually associated with poor clinical outcomes. Another unintended consequence is C. diff infection, which is a major, major issue at the VA. I'm not sure how big of an issue it is for you here at LSU, but we definitely struggle with this. So the goals of a good stewardship program are to reduce those unintended consequences, improve patient safety, reduce inappropriate antimicrobial use, reduce costs, and when this has been looked at in studies around the world, you can see that generally significant cost savings do come out of these stewardship recommendations, and also to reduce the cost associated with those resistant infections, which lead to longer duration hospitalizations. Having said all that, let's back up and look a little bit at the history of antibiotic evolution, if you will, going back to the beginning, which for most of us, we think of the beginning as the discovery of penicillin and streptomycin around 1940. One major point from this timeline that runs from 1903 to current is that a lot of new antibiotics emerged during the 1940s and 50s, and even quite a few more up until about 2000. And then, as I'll show in the next slide, the pipeline really started to dry up in a very distressing type of way. And part of the history there is that pharmaceutical companies in general found antibiotic development less profitable than development of drugs that almost everybody has to be on, like statins. That's where the money is. The money is not in antibiotics to treat relatively unusual infections. So this is what happened. And like I said, driven partly by capitalism, the pipeline just dried up during the late 20th century, almost to nothing during the years 2008 through 10. There was only one new antibiotic FDA approved during that 2-year time span. There has been a somewhat effective reaction to that concern, and partially spearheaded by the Infectious Disease Society of America, that has this bad bugs, no drugs, political hype that they've taken to Congress with some effect. And one effect is that the FDA does now have pathways for relatively easy approval of newer antibiotics that would have otherwise been more like orphan drugs that would have had a very difficult time being approved. And so the incentive for companies to develop new antibiotics has gone up a bit in the last 5 years. So what do we have? If we look from 2010 forward, we've got Taflero, which probably most people have heard of, ceftaroline, which is a broad-spectrum cephalosporin with coverage including MRSA and many gram-negatives, but just excluding Pseudomonas. Okay, one drug in 2010, one drug in 2011, a new drug for C. diff infection that's marginally, if at all, better than oral vancomycin in terms of efficacy, but much more expensive. 2012, one drug, kind of an orphan drug, that's for treatment of multi-drug resistant tuberculosis. 2013, one drug, telavancin, a glycopeptide, big deal. It's kind of a modification of vancomycin, okay? So there's very little creative going on in this list. These are minor incremental improvements over previous types of antibiotics with really not very much in the way of major breakthroughs. Ditto, 2014, okay? In 2014, at least, we've got 3 new antibacterials, but they're all minor incremental developments. 2 more glycopeptides, similar in mechanism and spectrum to vancomycin, and a cousin of linezolid, which has somewhat fewer side effects than linezolid. 2015, thus far we've got 2. Again, both minor incremental advances, that is combinations of cephalosporins with beta-lactamase inhibitors, one of which does have anaerobic coverage, so it's indicated by the FDA as monotherapy for intra-abdominal infections, one of which lacks anaerobic coverage, so its FDA approval is in combination with metronidazole for intra-abdominal infections. Couple of slides to make the points that in general during the years 2000 through 2010, antimicrobial usage was going up and up and up. And there have been corresponding increases during that time period in terms of the incidence of resistance to broad spectrum agents. So this slide just shows that broad spectrum antibiotic use was increasingly common in a number of medical centers during 2002 through 2006. Everywhere you look. Zosyn, 84% increase during that time span. Carbapenems, 59%. Vancomycin, 43%. So more and more antibiotic pressure out in the community. Can say the same thing for quinolone use for treatment of acute respiratory tract infection in outpatients. U.S. antibiotic prescription rates for acute respiratory tract infections in ambulatory settings. So for each agent that we're looking at here, it's broken down into age groups, and the red bars are 1995 through 1996, and the brilliant green-yellow bars are 2005 through 2006, so 10 years apart. And you see during that time the dramatic increase in fluoroquinolone use for the treatment of respiratory tract infections. Not so much change for cephalosporins and macrolides. So then at that point there was a lot of fluoroquinolone pressure out in the community, which gets relieved by the organisms by becoming resistant to the specific pressure, in this case fluoroquinolones. So this graph shows increasing fluoroquinolone use. That's this blue line during 1995 through 2000, paralleled by increasing Pseudomonas resistance to fluoroquinolones, and also by general resistance of gram-negative organisms to fluoroquinolones. So the organisms keep up with the pressure. Ditto for gram-positive. So this graph shows the increasing incidence of MRSA during 1980 through 2000, and also of VRE, and once again fluoroquinolone-resistant Pseudomonas. Part of the IDSA hype that's been sold to Congress is to talk about the ESKAPE organisms. This is what we're concerned about, these increasingly multi-drug resistant organisms. We need new drugs to cope with these things. ESKAPE, Enterococcus faecium, that's VRE, Staph aureus, of course they're talking mostly about MRSA here, but maybe also a little bit vancomycin resistant Staph aureus. Klebsiella pneumonia, which is the champion organism for cranking out carbapenemases, as well as other potentially highly resistant gram-negative organisms. So here's a little slide about the Klebsiella pneumonia carbapenemase. What is it? It's a beta-lactamase that confers resistance to all beta-lactams, including extended spectrum cephalosporins and carbapenems such as meropenem. And it occurs mainly in Klebsiella pneumoniae, but also across a spectrum of other gram-negative bacilli. So in part because we're faced with this increasing resistance to newer agents, there is a trend to need to dig back into the older agents to look for activity. And the best example of this is the use of colistin to treat multi-drug resistant gram-negatives such as Acinetobacter. And there is quite a bit of support for doing this if the strain is susceptible to those types of agents. They are very kind of primitive types of antimicrobial agents in the sense that the mechanism is that they just increase cell membrane permeability and make the cells leaky, like amphotericin does to fungi. So they have a detergent-like interaction. They're active generally only against gram-negatives. The organisms can become resistant to the agent by changing their lipid A content in the cell membrane. And they're associated with toxicities, including nephrotoxicity and a variety of different neurotoxicities. But we do resort to colistin increasingly now because we have to. So those are all the general comments I wanted to make as an introduction. Now I want to talk to you a little bit about what's known about antimicrobial use in the VA system, which of course has many weaknesses that may be talked about more than the strengths, but one of the strengths is the computer system that's interconnected throughout the nation and is fairly mineable by the right people, so we can look and see what's going on with antimicrobial use throughout the country. And the data I'm going to show you comes from the VA National Pharmacy data. What this system can deliver for us is the number of patients receiving care by site, the number of patients receiving antimicrobials by site, and the defined daily doses of parenteral therapy. Now, what's a defined daily dose? An example would be vancomycin. One way to express vancomycin usage is for an individual whose ideal body weight and has more or less normal kidney function. That defined daily dose would be 1 gram IV Q12 hours. That's a defined daily dose. What this system can't deliver to us is, at least currently, is rates of antimicrobial resistance, and there are people working on that aspect of it currently, because it would be nice to have that. One thing that's very interesting about the VA system is that similar complexity facilities across the country, like 1A facilities, do a lot of things differently from each other. And one of them is antimicrobial use. Just because you're a highly complex, large facility doesn't mean that you're necessarily using the same defined daily doses of antimicrobials for some reason. And so maybe there's an opportunity there to change behavior in 1A facilities that are using a lot more antibiotics than others. So among similar complexity VAs, you see different lengths of stay for similar conditions, different rates of readmission, different culturing practices, for example. And to bring the real world perspective, showing how different VAs can be, this is not the view from my office in the Shreveport VA. This is the view from somebody's office at the San Francisco VA. They're a lot different, these facilities are. So let's look at inpatient and outpatient antibiotic use in fiscal year 2009 across the 20 largest VA facilities in the country. They're complexity level 1A, except as noted, so let's not get bogged down by looking at these things here. I'm not too sure what the units are for antibiotic use over here, so let's just think of this as a relative comparison across big bars and little bars on the graph. So here on the left-hand side, you have complexity 1A facility number 15, which has been de-identified. I don't know which VA that is. These people really like to use a lot of inpatient antibiotics. Then over on the right-hand side, you have another 1A facility. I can't read which number it is. Maybe it's 13, way over here at the right. And they really don't like to prescribe so much in the way of IV antibiotics. That's de-identified too. Now, if you're thinking actively right now, you may be going, well, there could be factors played in there that may bring sense to this picture, like maybe one's a transplant facility or something like that. I don't really know. But just look how this shakes out if you look at all aspects of antibiotic use for number 15 versus number 13. What if you look at big gun anti-gram positive coverage across the facilities? You get the same pattern here, 15 versus 13. What if you look at anti-pseudomonal big gun gram-negative antibiotics across the 20 largest stations? Similar type of pattern. What if you look at broad-spectrum agents, which are, oops, I went backwards, which are not anti-pseudomonal, but they're almost that broad in coverage? Same thing. Facility 15 here on the left, 13 on the right. What if you look at inpatient fluoroquinolone, Bactrim, and azithromycin? Same thing. Maybe there are modifiable behaviors in here, I'm not sure. And then this is outpatient use for those same types of agents with a similar pattern. To the extent that maybe some of that usage is modifiable by a team approach to prospective antimicrobial review and intervention and feedback, then maybe it's a good thing to talk about antimicrobial stewardship programs. And there's basically a couple of different approaches that can be taken. One is what's called a front-end approach. And I was very involved in this when I was on the faculty at Wake Forest. We called it the antibiotic police. And here's the way it works. Is, you have a list of the newer, recently approved antimicrobials that the pharmacy is trying to conserve and maybe has made them non-formulary or at least criterion-based prescription forms, and the intern wants to prescribe one of those antibiotics in the middle of the night to a new admission. The page has to go to the ID fellow on call. And those fellows were miserable because they were up all night every night taking these non-formulary phone calls for front-end stewardship. That sucks. It destroys collegiality between ID and everybody else in the hospital. It's very unpleasant. I don't recommend it. But what it does is to improve appropriateness of empiric antibiotic therapy on the night of admission. It also can lead to optimized dosing and monitoring early during antibiotic therapy. And it's been demonstrated in the literature that it has some salutary effects, including increased gram-negative susceptibility to the commonly used agents and decreased C. diff rates. Then there's what's called back-end stewardship. And that's probably more the flavor of what we're doing in the ICU at the VA. This occurs at opportune times for interventions. So the patient's been in the hospital for a few days. Now the cultures are returning. And so at this time, we can look for opportunities to streamline that vancomycin regimen down to a focused penicillin regimen for susceptible strep viridans in the blood. That's back-end stewardship. A little bit later, if we review that same patient, maybe we can even give a stewardship recommendation that would say it should be safe to switch to oral therapy at that point. And then more like on days 7 to 14, we can look with a focus of not giving too long of a duration of antibiotics unnecessarily. What about different stewardship strategies? What works and what doesn't work so well? This is played out in the literature in the IDSA guidelines, and I provided that reference at the beginning. The very most effective is what's called prospective audit, intervention, and feedback. That's similar to our approach in the ICU at the VA. So twice a week, the stewardship team is reviewing every record in the ICU with a specific focus on culture results, antibiotic use, and the big picture. And then rounding with the team and saying, hey, we noticed that maybe there's an opportunity to focus or something like this. And why we're making that recommendation. This increases collegiality. It's not a roadblock, it's a positive thing. Another very effective strategy is also the formulary restriction and criterion-based order forms. That's a little bit more of a negative approach, but it can be very effective too. I always like to cite Dr. King's and Todd's reference about an era in this hospital where there was increasing resistance to gentamicin as the formulary anti-gram-negative aminoglycoside. And the reaction that came from this team was, well, let's switch our formulary aminoglycoside to amikacin. And within a short period of time after this intervention was done, in fact, the susceptibility to gentamicin went back up again within the hospital. That's how fluid this antibiotic pressure is in a hospital-type setting. If you take the pressure away, in general, the resistance will go away. What's less effective is what's called just routine antibiotic cycling, which is not directed. It's kind of a random cycling. Educational programs like this talk that you're sitting through, it's probably not going to work, but thanks for coming. Practice guidelines, I particularly like pointing that out. Guidelines aren't all that effective. Automatic stop orders, I'm sure we've all seen this. ID docs, many of us feel that these are actually destructive and that sometimes antibiotics fall off the order set without us really being aware of it. And substitution programs. If we're going to institute a stewardship program, we should also be interested in measuring whether it's having any effect or not. And the effect that I like to look at is the process measures. Basically, what this means is if we, as a stewardship, make a suggestion, does it get followed? That's a process measure. And, you know, the recommendations would be things like right drug, right dose, right route, right duration. We can go back after those ICU rounds and look to see whether the home team actually did those things. That's solid data. We know what the cause and effect was. The cause was that we made a suggestion, and the effect was that they liked it okay and they did it. And they understood the rationale. Outcome measures, in a way, are more attractive because, you know, here, you know, in terms of stewardship, outcome goals are to look for things like decreasing antimicrobial resistance in a hospital, decreased adverse events, decreased costs, C. diff infection, and maybe even mortality. In one sense, I find these attractive, but in another sense, as a scientist, I find it ostentatious to say that because you institute a stewardship program, that's the cause of C. diff infection rates going down. How do you know? How are you going to control for that? I think that's presumptuous. It may be of interest to look retrospectively and see whether it happened or not. But to suggest cause and effect, I think, is going way too far. Now I'm just going to talk a little bit about personal experience with different stewardship programs in different settings, and then finish up by showing you some of our numbers from the VA over the last few years. So the first stewardship program I was involved with was at Wake Forest School of Medicine, which I'm showing here. This is a private medical school setting, which had, at the time that I was there, a front-end stewardship program, which was the antibiotic police, the fellows getting paged in the middle of the night to get permission to prescribe newer agents when older ones might have worked. Again, it's somewhat effective for containing costs, limiting unintended consequences, but it's no fun and it can disrupt collegiality. Then in private practice at an even larger hospital in Winston-Salem, Forsyth Medical Center, which at the time was the largest hospital in North Carolina, about a 700-bed hospital, we had a prospective audit, intervention, and feedback, kind of more of a back-end type of approach in collaboration with a full-time pharmacist who was dedicated to this one task, who was really an expert, and that was fun. The way this worked, our private ID consulting team had a contract with the hospital to round 1 hour per day with this dedicated pharmacist who otherwise would spend all of his time looking at all antibiotic use in the hospital and then boil all that work down to 5 or 6 really complicated cases that needed the eyes of an ID clinician on it. And we would provide those eyes for 1 hour per working day, Monday through Friday, throughout the year for a nice chunk of money. This was fun. It was very effective. Our acceptance rate for these recommendations were roughly 90%. And it was really rewarding to work in collaboration with this type of expert, this pharmacist. Our most common recommendations were to focus down, narrow the spectrum, fix mismatches between susceptibilities and therapy, which are actually fairly common after the culture results come back, and IV to PO switches. What are we doing here? We actually have to fill out a checklist every year at each VA facility now and report nationally what are we doing with stewardship. So what we're doing in Shreveport is formulary restriction. Certain antibiotics are criterion-based, order form specific, and I've listed them here. We monitor timing of perioperative prophylactic antibiotics and also timing of antibiotics for treatment of community-acquired pneumonia. And we do these twice weekly prospective audits in the MICU and SICU, as well as prospective audits of all positive blood cultures in the hospital, which isn't that hard to do in a 110-bed hospital. It would be hard to do at a place like this. First, let me tell you what we're doing in the ICU in these twice weekly rounds. We review all antimicrobial use in the ICU, followed by intervention and feedback. That is suggestions during rounds with the ICU providers, getting their feedback, and then us getting feedback from them as well. Our review includes a kind of like a quick EID consult. We look at the clinical history, culture data, other laboratory tests, and radiographic studies. And then we make suggestions for optimizing antimicrobial regimens, and we keep score just for fun, because that's a process measure if we keep those numbers. So the numbers I'm going to show you are a 2-year period where we tracked acceptance rates of our recommendations. And so what did we find? Okay, in a relatively small hospital setting like our VA during 2 years, when you talk about going to review every chart in the ICU twice a week, what you mean is you're reviewing about 1,000 charts in 2 years. And what we found was that approximately 60% of all of those patients we reviewed were receiving at least one antimicrobial agent. Well, how did that break down? So this target here shows the breakdown for those who were receiving antibiotics, the 60%. Among those, 41% were receiving just one antimicrobial therapy, 37% 2 agents, 16% 3 agents, and 6% more than 3 agents. This pie chart shows the same thing. If you might find this easier to look at, 60% receiving versus 40% not, and then the breakdown of how many agents the various people are getting. So out of those 1,000 and some reviews, how many opportunities did we see? Only about 17%, I think, which speaks fairly well for the baseline level of sophistication of the medical community we're operating in here, because I've seen publications where this number is more like up in the 40 to 50% range. Or maybe that just means that the ID doctors here are dumb and they're not identifying the opportunities, but I'm not going there. And out of, let's see, so 196 reviews led to suggestions. How many suggestions? Sometimes more than one per patient, a total of 228. And what was the acceptance rate? About 90%. And all that's broken out in this little graph down here. Comparing this to the literature, that's pretty good. That means that we're working in an environment where we listen to each other. What kinds of suggestions? This is somewhat interesting, especially when you contrast the kinds of suggestions for ICU rounds versus blood culture reviews. In the ICU, our most common suggestion actually has been to modify antimicrobial dosage, and usually that's in reference to renal function. Our second most common is to adjust the duration. This can either be to lengthen or shorten the duration. In an HCAP, the recommendation might be to not continue past 8 days, for example. The third most common, which is actually way down the list, is to narrow the antimicrobial spectrum. And that, I think, for ICU people really makes sense. You're dealing more with empiric therapy of critically ill people than you are with cultures in hand and really knowing what your pathogen is. And then you see some minor categories below. What about the blood cultures, though? By the way, the rationale in a kind of a resource-limited little VA like ours for just picking on the ICU and the blood cultures is that those are all the most critically ill patients with infectious syndromes. We focused our limited personnel efforts on the sickest patients, so that's ICU and people with positive blood cultures. What we do in the case of the blood cultures is weekly to review all positive cultures, to weed out all those that look like contaminants, 1 out of 4 bottles positive for Corynebacterium or what have you. Then to access the antimicrobial regimens in the computerized patient record. Then to suggest opportunities for improving the regimen, and then to track and record acceptance rates, in this case during 18 months with 100% acceptance rate. I hope the print is large enough that you can kind of read this, but one set of data that I wanted to show you is the spectrum of organisms with relative frequency that are causing positive blood cultures at the VA here. And although in many facilities Staph aureus would lead the list, in ours by just a little bit E. coli does. And although I've not specifically looked to verify the reason for this, I think just by seeing ID consults there that a lot of what's going on is just that a veteran population is typically older males with partially obstructed lower urinary tracts, and they get a lot of UTIs. So E. coli is number 1, MRSA is number 2, MSSA is number 3, and we've got a little bit of everything in there. If you look at a comprehensive list, we get some unusual ID consults for bacteremic patients. Now in this case, if we look at the array of suggestions relative to frequency, the number 1 is to narrow the spectrum of antimicrobial coverage. And I think that also makes sense, because what we're dealing with here is now a known pathogen, a known susceptibility pattern. Question, why are we treating a strep viridans with vancomycin instead of penicillin? That's kind of how these blood culture reviews work in general. So these are our process measures. We've not started looking at outcome measures yet, although there's some enthusiasm for doing that, and we could do that. And that's everything I have to say right now. So thanks for listening.
Have you found that short of I personally found it helpful. We have a clinical pharmacist who rounds with us, and she's not pleased, but she will throw out questions occasionally.
Yeah.
Why are you using this? Why don't you use that? And I'd say more than half the time we say, yeah, that's a good thought, and change our behavior on the spot.
Right.
Do you find that useful?
We don't have anything exactly analogous to that. Dr. Marion, I know what you're referring to. It's like an embedded pharmacist probably on a ward team, right? Yeah. We're not doing that. I'm not sure if we have the resource for that, but in previous lives, like in private practice life, I have seen that, and my sense is that it's very useful and very productive. The thing that we are doing that's somewhat analogous is to have a pharmacist on those ICU rounds with us, and she's reviewing all medication use actually, but also with a special focus on antibiotic use, and that's fun. You know, usually we'll arrive at rounds two minutes early and ask each other what we have on our hit lists just to compare notes, and then come to a consensus about the things that we're actually, you know, going to think are so important that they should be raised on rounds. Any other questions? Thanks for your patience.